I'd like to welcome you all and thanks for inviting me to talk about one of the very important jobs and tasks of endoscopic ultrasonography, which is staging of malignant pancreatic masses. Malignant pancreatic masses may be adenocarcinoma, cystic pancreatic neoplasms, neuroendocrine tumors, lymphoma, or metastasis. The commonest pancreatic carcinoma is ductal adenocarcinoma, accounting for about 10% of all pancreatic carcinomas. It may be acinar adenocarcinoma, also mucinous cystadenocarcinoma, intraductal papillary mucinous carcinoma, serous cystadenocarcinoma, pancreatoblastoma, solid pseudopapillary tumor, Spen or France tumor, and the rare osteoclast-like giant cell tumor. Pancreatic cancer constitutes about 3% of all new cancer cases in the United States. The number of new cases of the pancreatic cancer was 12.4 per 100,000 population per year. And unfortunately, the number of cases have been rising about 0.8% each year for the last 10 years. And also, very unfortunately, the 5-year survival is ranging between only 5 to 7.2%. We all know that the only real hope for cure is radical resection. So, before you have an accurate decision of surgery, you must have an accurate staging. The staging of pancreatic cancer is according to the famous TNM system, tumor node metastasis, but we should mention the resectability of the tumor, whether resectable, borderline resectable, or unresectable. This is the TNM staging of pancreatic carcinoma in 2017. T1 tumor are tumors limited to the pancreas and less than 2 centimeter in the greatest dimension. T2 are tumors between 2 and 4 centimeters. T3 are tumors larger than centimeter in its greatest dimension. T4 is a tumor involves the celiac axis, superior mesenteric artery, and or common hepatic artery, regardless the size. We should stop about the word involves. What is meant by a tumor involving a vessel? Is it touching the vessel? Irregularity of the vessel at the site of the tumor, occluded vessel, engulfed vessels, pinching, extension, compression, displacement, shifting of the vessel, flattening, obstructing. All these terms are correct, but I think the most correct term is loss of the interface between the tumor and the vessel. This is the normal vessel, splenic vein, and this is the pancreatic tissue. And here you notice that there is a nice line, nice white line of interface between the pancreatic tissue and the vessel. This is in the linear endoscopic ultrasound, and here this is a very clear line of cleavage or clear line of interface or clear line of separation between the venous confluence of the portal vein and splenic vein. And here this is a very nicely seen whitish line of cleavage or contact between the pancreatic tissue and the vessel. This is a video showing pancreatic body mass, and here this is a venous confluence, and we notice here that the line of cleavage or the line of separation is very nicely seen, very well defined, this whitish line. So this tumor is not involving that vessel. This is in contrast to this pancreatic head mass that produces irregularity of the portal vein at the site of the tumor. And here this is the aorta and the celiac axis. And here we notice that the pancreatic body mass producing marked irregularity and even compression of the celiac axis. So this mass is involving this vessel. And here in this picture, even the mass is infiltrating inside the celiac axis. This is a part of the soft tissue area inside the celiac axis, continuous with the original pancreatic body mass and also having the same echogenicity. So it is mostly an extension of the tumor inside the vessel and not a thrombus. If it is a thrombus, it is usually more hypo or more hyper than the original mass, but here they have the same texture, so it is a tumor invasion. From a clinical point of view, the goal of preoperative staging of pancreatic cancer is to identify three different terms. First one is resectable tumors that should be referred directly for curative surgery in surgically fit patients, borderline resectable tumors that can be considered for neoadjuvant chemoradiation for downstaging, then possible resection with or without vascular reconstruction, and the metastatic or unresectable tumors that should be directed to palliative chemotherapy. In order to determine the resectability of the mass, we should know three important points. The first one is which vessel is involved. Is it the aorta, celiac axis, superior mesenteric artery, superior mesenteric vein, portal vein, or portal venous confluence? This is a very important vascular structure. The splenic vein and artery are not important because the spleen can be removed with its vessels. The second point is the pattern of involvement. It is abutment or encasement. This is especially important for arteries. And the third point is the length of the vessel involvement. This is important especially for veins. What is meant by abutment and encasement? Abutment is involving less than half of the circumference or less than 180 degree of the circumference of the vessel. If it is a cancer, so it is involving less than half of the circumference of that vein. This is called abutment, while encasement is involving more than half of the circumference or more than half 180 degree of the vessel. This is a picture showing this is a superior mesenteric vein, and this is a large mass in the head of the pancreas. And this is a superior mesenteric artery, so the superior mesenteric artery is not involved, while the mass is in contact with the less than half of the circumference of the superior mesenteric vein. So this mass is abutting the superior mesenteric vein, yes, abutting the superior mesenteric vein while it is away from the superior mesenteric artery. So not involving the superior mesenteric artery, but abutting, involving less than half the circumference of the superior mesenteric vein. This is a video showing encasement. Encasement means involvement of more than half of the circumference. This is a large mass, and this vessel is totally inside the mass. The mass is surrounding the vessel from the whole circumference, so it is encasing this vessel. Okay. According to many societies, cancer societies, the definition of borderline resectable masses includes superior mesenteric artery abutment for less than 180 degree, abutment of the superior mesenteric vein. If the superior mesenteric vein is encased, then it is a non-resectable or unresectable tumor. Abutment means borderline resectable. Away from the vessel means resectable. The second is common hepatic artery, short segment abutment or encasement with no extension to the celiac axis. There is 1 centimeter free of the common hepatic artery near its origin or at its origin from the celiac axis. So if the mass is extending, involving the common hepatic artery till its origin from the celiac axis, then it is unresectable. While if there is 1 centimeter free, then it is a borderline resectable. Gastroduodenal artery encasement up to the hepatic artery, this renders the mass borderline resectable. Superior mesenteric vein or portal vein abutment, encasement, or short segment venous occlusion, but with suitable vessel proximal and distal to the area of vessel involvement, allowing for safe resection and reconstruction. So if there is involvement but with a suitable area, then it is a borderline resectable. or if there is long segment of involvement, it renders it unresectable. And the length of this vessel involvement is judged by most of the surgeons to be about 1.5 to 2 centimeter, about 2 centimeter. If the involvement of more than 2 centimeter, then there is difficult reconstruction and renders it unresectable. But if it is involving within 2 centimeter of the vessel, then it is a borderline resectable with possible reconstruction. If the celiac axis, aorta, or inferior vena cava are involved, then it is unresectable. They should be not involved at all. Involvement of the celiac axis, aorta, or inferior vena cava renders the mass unresectable. To be borderline resectable or resectable, these vessels should not be involved, except for M.D. Anderson, which stated that in cases of pancreatic body mass, not head, pancreatic body mass abutting the superior mesenteric artery, then it may be borderline resectable and not unresectable like other societies. This is an example of a borderline resectable mass. This is a large pancreatic head mass, and this is a common bile duct with a plastic stent inside, and the pancreatic duct with a plastic stent inside. And here, this is a portal vein. Here, this is a portal vein. The line of contact is about 1.5 to 2 centimeters, so it is borderline resectable mass with possible vascular reconstruction. In contrast, this mass, this pancreatic body mass, yes, this is a large pancreatic body mass, and here this is the superior mesenteric artery. Here, the superior mesenteric artery, yes, this is the superior mesenteric artery, very nicely. This is the abdominal aorta, and this is the superior mesenteric artery arising from the abdominal aorta, and this is the celiac axis arising from the abdominal aorta. Here, the mass is abutting the superior mesenteric artery. Till now, it is a borderline resectable mass, but this is the celiac axis. It is totally encased by the mass. The mass is totally surrounding the celiac axis, so it is an unresectable mass. So this mass is abutting the superior mesenteric artery and encasing the celiac axis. Yes, this is the celiac axis, totally encased by the mass. Okay. Then what is the weight of endoscopic ultrasound in cancer pancreatic staging? Is it the best modality? So let us compare the accuracy of endoscopic ultrasound and CT in cancer pancreatic staging. 11 well-designed studies compared between EUS and CT for preoperative staging of the pancreas. Regarding the T-stage accuracy, 4 of 5 studies concluded that EUS was superior to CT. And EUS was also superior to CT in end staging in 5 of 8. 5 studies out of 8, and here 4 out of 5. So it is a little bit better than CT in staging of pancreatic mass and assessing the lymph nodes. Regarding comparison of endoscopic ultrasound and MRI, both most of the studies stated that they are both equivalent in end staging and vascular invasion. So endoscopic ultrasound has a heavy weight in evaluating pancreatic cancer. They are very accurate in staging, as accurate as MRI, and a little bit more accurate than the CT. And it is also very beneficial in evaluation of vascular invasion and resectability. And the great advantage of endoscopic ultrasound over CT and MRI is the ability to do instantaneous, easy, and safe tissue sample. So we came to our conclusions or take-home messages. It is very important to stage borderline resectable pancreatic tumors for possible new adjuvant chemoradiation for downstaging and possible vascular reconstruction during radical surgery. AUS, multi-detector CT, and MRI are the available tools for tumor staging. However, the possibility to obtain samples from suspicious lesions or lymph nodes by means of AUS-FNA makes this procedure an ideal diagnostic and staging modality for pancreatic cancer. And thanks for your attention.